or we were, thank you, Britta, we believe ComEd, who may have been doing some tree work outside of Kim's house, may have done something wrong, so her power is now out. So I'm just quickly taking over for her. So, welcome. This is one of 3 trainings developed for the Outreach Advocating for Safe and Inclusive Spaces for LGBT Older Adults initiative that was developed by the Out Aging Committee, which is housed at the Pride Action Tank, also known as PAT. The other 2 trainings in this series are Storytelling for Change and Advocacy for Change, both of which have a cohort model. Kim Hunt is the executive director of PAT, which is a project of AIDS Foundation Chicago, where she serves as the senior director for policy and advocacy operations. Unlike our other 2 outreach trainings, where all the attendees are LGBT older adults, this training is for that group as well as anyone who has an LGBT older adult in their lives, personally or professionally. For the latter, we are fortunate to partner with Center on Halsted. They are offering 1.5 CEUs that will be awarded at no cost to social workers and professional counselors. So stick around to the end to find out how you can submit a request for those credits. So the overarching goal for this morning's program is to provide LGBT older adults and their allies with tools that improve their autonomy and agency in various service settings, and to equip service providers and people who have LGBTQ+ older adults in their lives with tools to advocate for policy and program changes. We also have 3 practice-driven objectives: to provide information about the rights of LGBT+ older adults, including the Equity for Elders Act and Disrupting Disparities for LGBTQ older adults and older adults living with HIV bill, to develop an understanding of the role of allies and how to show solidarity in healthcare and other settings, and show the importance of continued advocacy for LGBT older adults through public policy. Now, a few housekeeping details. We are using regular Zoom, which means we can all see and hear each other. So please remember again to keep your microphone muted unless you have been asked to speak. Also, as someone who has spoken into the void of black boxes over the last 2 years, and we all have, it'd be nice to be able to see your faces. So if possible, I encourage you to keep your camera on, but I do understand if you don't have the energy for that, or maybe still eating your breakfast. We've built in time for Q&A, but you can put questions and insights in the chat at any time, and I will be keeping track and monitoring the chat. So we're fortunate to have some fantastic trainers today who many of you have worked with in the past. They are Britta Larson from the Center on Halsted. Oh, look at that. And you might want to turn your votes on mute. That was a call from Poland. Sorry. Where was I? Oh, sorry, Britta from Center on Halsted, who will talk about advocating for self and others in healthcare and other settings. Dr. Margaret Danilovich of Leonard Shanfield Research Institute at CGA Senior Life and Northwestern, who will discuss the importance of exercise for older adults living with HIV, and Mary Anderson of AARP Illinois, and Mike Ziri of Equality Illinois, presenting via video. They will talk about legislation focused on LGBT older adults passed by the Illinois General Assembly this session, and each presenter will say a little bit about themselves before diving into their topic areas. And we also have 2 storytellers joining us today, both of whom have completed the multi-session storytelling trainings at HFC and PAT. So I will introduce them now. Lee Payne is a retired social worker, educator, and community organizer. Lee was a founding member of the Human Rights League in Milwaukee, Wisconsin, where she worked to advance the political interests of the LGBTQ community. Lee relocated to Chicago, Illinois in 1995, where she continued her work as a social worker and activist for women and children. She is a former board member of Chicago Black Lesbian and Gays and currently volunteers to assist aging individuals with accessing quality medical care and coordinating resources. A lifelong learner with lived experience and passion to give back to and create change, Brian Gooding considers himself an advocate, activist, sometimes agitator, with almost 20 years of experience advocating for people living with or at risk for HIV/AIDS and healthcare as a human right and social justice equity issue. For over a decade, Brian has worked directly with and at-risk marginal communities in the Chicago metro area, providing education, prevention, early intervention, and linkage to care services. And now Lee will kick us off with her story. Lee, you're muted.
Thank you for the introduction. This is my story. It was a Friday, January morning, the year of our Lord, 2011. I slowly moved from my bed to open my blinds from the view of the magnificent Chicago skyline and frosty Lake Michigan. Living high, but feeling low. My mind was in the clouds over the lake. You see, today, I would move on to another view, a view of my digestive system. My destination, the University of Chicago Discovery Center. My body was drained of what once was electrifying energy. I was slow to get dressed. Uncertainty entered my mind a million times over. What would they discover? The past few months for me were filled with whys. Why did I feel this way? Why me? And why no one seems to know why? For the first time in my life, I felt helpless and alone without hope. I searched my soul for that Black lesbian warrior spirit that once was no more. I had no armor, no protection from the free radicals attacking my anatomy. Stripped of my being, but determined to continue to stand, and that I did. Within the next 2 hours, I had arrived at the hospital for another dreaded and undesired medical adventure. My anxiety was raging and rising. It was now on the ceiling of my enclosed space, a bed, a chair, and a device to monitor my vital signs. The anesthesiologist approached my bed, documents in hand. I followed his eyes as he glanced over them. He then looked at me strangely and stated, I was reviewing your results from last week. So you have the same disease Walter Payne had. My response, Walter Payton is dead, sir. The running back for the Chicago Bears, the Hall of Famer, the great running back. He was famous, wealthy, and only 44 years old when his short life ended. He explained to me that I have PSC, primary sclerosing cholangitis, a rare and debilitating disease that affects only 3 in 100,000 people and leads to liver failure. There is no treatment or cure for this disease, and no one knows why it invades the body. Me, I was shocked and afraid. The tears covered my face. I would no longer exist. One whose life was about to end soon, I thought. I don't recall much more about that day, but my numb body returned home with unidentifiable emotions. The following day, I received a call from the hepatologist. She spoke as if she was irritated. How ironic. She confirmed my diagnosis and told me to go to the county hospital because it would be 30 days before my insurance would cover my medical costs. The county, I thought, it would take months to get an appointment there. See, I had been a patient at this hospital for 10 years. It was no secret that I was openly gay. It was obvious that my existence meant absolutely nothing to this physician, so I hung up the phone, lost without a cause. 2 weeks later, depressed and frail, I asked a friend to take me to Northwestern Hospital. Again, a room full of doctors. I mustered up enough strength to tell my story. You see, after 25 years plus as a social worker, advocating for and providing healing spaces for children with no homes, women who were abused, and anyone considered a have-not, I figured I better do a damn good job of advocating for me. You see, dying was not on my agenda. My life would not cease to be purpose-driven. Minutes later, a physician with a smile entered my room with the words I so desperately needed to hear. I am going to help you. Maybe there was some miscommunication between you and the other doctor. These words kept breath in my body, but 2 years later, I was no longer able to work. 2013, I was homeless, jobless, and living off the generosity of my high school friend, John, who I had reconnected with after 30 years. Unlike my biological brothers, who I felt were ashamed of my sexual orientation, but whom I loved with all my heart, John's love for me was unconditional. He graciously funded my healthcare costs, along with my church family. They were and still are my saving grace. I waited 2 years to get a check for $800 from SSI. I waited another 2 years for the SSDI. You see, I had worked from the time I was 16 years old, but they only saw fit to give me a monthly check that still does not cover my basic needs. After visiting the Chicago Housing Authority office and being told that the housing waiting list was 25 years, I had to move into a building managed by slumlords. Today, I still wait for subsidized housing. I live in the third largest city in the United States, and there is no adequate housing for me to live or to heal. Eating healthy was not an option. According to the Department of Human Services, my $1,400 a month I paid into the system would only allow them to give me $48 a month in SNAP benefits and require me to pay a $550 spend down payment for Medicaid, which I cannot afford. It is mandatory that I have a caretaker. But you see, I have had several caretakers to come into my home, never one who has stated to me that they have received training to provide services to the LGBTQ community members. My name is Lee. I am a queer woman who was once the provider for those living in poverty and distress. Today, I am them and they are me. Is this not America, home of the brave and land of the free? Have I not been brave and courageous? Even though this society refuses to fully give me the justice and equality that I deserve, I will continue to fight, advocate, and help others to access quality healthcare and seek the limited resources that are available. I will never give up, and I will not have my pride and dignity taken away. I will never give up until the day God calls my name. I have one request of the American government, the government with a majority that refuses to acknowledge my humanity and validate me. Please do not take away my life, liberty, or pursuit of happiness, for I will never take away yours. Thank you.
Thank you so much, Lee, for sharing your story with us. It is an amazing introduction into the rest of our time today. So I'll introduce myself and then I'll move forward with some of my comments and my remarks around advocating for change. So my name is Britta. My pronouns are she and hers. I'm Director of Senior Services at Center on Halsted. I've been at the Center on Halsted for 12 years. Prior to my time at Center on Halsted, I worked in long-term care. So I have seen both, mainstream aging services up close and personal, and I have had the privilege of working with some amazing folks at the center, many LGBT older adults who, to your point, Lee, are out there advocating for the services that they deserve. And to your point, unfortunately, many times the system lets us down and those services don't exist. So I'm going to share my screen, if that's okay with everyone. Give me one quick moment. I have a PowerPoint. Let's see if I can get that up. Okay. All right. So just some quick introductory questions to kind of get us thinking about the topic today. So do you know an older adult who has accessed aging services? And I think most of us on the call here today have. And so the question is, what was their experience? And what factors contributed to that experience? And so I want you to kind of take a second to think about that person that we're thinking of, and kind of carry that with that thought through the conversation today. It's interesting when we think about some of the folks that we know who are LGBT, who may not feel comfortable identifying as such. So you may know that they're LGBT, but other people don't, or you may be aware of their identity, but they're not feeling safe to disclose that. That can be the case oftentimes. And from what I've seen, really, people who are the most vulnerable in our society are having the hardest time in the aging process. So we're going to kind of talk about some of those factors. And so I had just a fun activity. So I just wanted to, we're going to talk about a lot about challenges, but let's uplift some strengths. So what are some strengths of LGBT older adults? What characteristics would you like to bring forward and uplift? If everyone wouldn't mind just maybe popping it in the chat or unmuting and just sharing that with the group. I think it's nice to center that into the conversation at the very beginning as well. And if you put it in the chat, I'll read it. Knowledge and experience, community building, living history. Yes, Kim. Resilience. Stories of joy. Humor. Leaders. Compassion for others. Creativity. Oh, excellent, Margaret. Advocacy, resilience, and fortitude. That's great. Thank you all so much for doing that. Yes, that absolutely 100% is what I have the privilege of seeing every single day at Center and Halstead, are all of those characteristics and more. And when we are thinking about this population, what are some barriers? What are some challenges that LGBT older adults are facing as they age? And I know many of you on the call today, so I know that you know this work intimately. And someone already put in the chat isolation, which absolutely is one of the biggest challenges LGBT older adults are facing. What else?
Lack of family support.
Yes, lack of family support. Absolutely. Complex health issues, health disparities, not feeling welcome in LGBTQ spaces. Untrained providers. Yes, absolutely. Misunderstanding. An aging system that's really designed to have older adults rely on their children and biological families. Stereotyping. Yes, excellent. Feeling like we have to go back into the closet, facing hostility. Great, thank you all so much for doing that. I really appreciate that. So I think that helps us sort of ground our talk today and remind us of some of the work that still needs to be done. There is plenty of that to do. We are making strides, but there is still plenty more to do. Okay, so another thing I wanted to bring forward around this conversation is the topic of advocacy. And it's really twofold when you think about advocacy with the lowercase a and advocacy with the uppercase A. So lowercase advocacy is really that individual advocacy, advocating for an individual client. I know many of us are working with LGBT older adults and advocating for them every single day. But then there's really the capital A advocacy, which is systems advocacy. I think it's helpful that we have that in mind as we move through this talk, thinking about both what we can do more one-on-one and more individual advocacy, but also big picture change as well. So I kind of coined the phrase person-centered advocacy. I don't know if that even exists, but I think it's helpful to think about how to set up a relationship to best help clients, and that the foundation of that relationship is going to be building a safe and being a safe and trusted advocate and really building that rapport with the client. And that takes time, and that is not easy. And that comes with lots of challenges because LGBT older adults are already coming to us with fear and mistrust of providers, rightfully so. In my experience, LGBT older adults may test the waters, if you will. They'll be very subtle about sort of disclosing their identity to you, and you really need to be sort of listening for that and supportive of that when they do come out to you. They may never fully come out to you. It's a process, and I think it's helpful to just meet the client where they're at. So certainly some clients are very, very out and proud and very comfortable disclosing their identity, and others are more hesitant to do so. And when I think about people who are more hesitant to disclose their identity, they generally they're more vulnerable and more at risk. So they have more to lose. So many LGBT older adults go back in the closet when they move into a skilled nursing facility, just because they are completely dependent on the care of staff in that context. And they are living alongside people who may not be, other seniors who may not be welcoming of the LGBTQ community. And so for fear of how they'll be treated, they go back in the closet for safety. And so the rest of the time today, I wanted to take, speaking of sort of the most marginalized and the most vulnerable of the LGBTQ community, I wanted to spend a few minutes talking about how to build rapport and establish that you're a safe person. And one of the ways is really language and terminology. So I wanted to spend a few minutes talking about that because respect can be conveyed through your use of words and language. And for the LGBT community, it's rapidly evolving terminology and language, especially driven by young adults. And so language does evolve over time. So the word queer is a great example of meaning different things to different people. And many young adults identify with the word queer, and many older adults have a strong negative association with the word queer. But I also wanted to encourage everyone to avoid making assumptions based on language, or just avoid making assumptions in general. That is something that all of us do every single day without necessarily even being aware that we're making assumptions, right? So we make assumptions based on how someone presents, or how someone dresses, or the pronouns someone uses, or who someone is perceived to be dating. All of those assumptions can be really detrimental to the individual. And so it's a great reminder for us all to just pause and backtrack a little bit and check our assumptions and ask. Ask how someone identifies, ask someone's pronouns, ask how they would like to be referred to, and to not make those assumptions. And so I'm kind of shifting the conversation a little bit to talk specifically about the trans community, because the trans community really is one of the more vulnerable communities within the LGBT umbrella. If you're following the news, you know that there are laws being passed in many states that are anti-trans, attacking trans youth. We have the trans bathroom bills, and those are the stories that we hear about in the news, but there are actually many, many, many more laws across this country that are being passed or attempted to be passed, or policies that are really, really attacking the trans community. And so I think for all of us on the call today, all of us are pretty familiar with, I think, generally the LGBT community. So I wanted to just take a quick moment to highlight some specific context for trans people, trans seniors, but of course, trans people of all ages. And so our society just really, we have sex and we have gender, and sex is assigned at birth, and gender is a socially constructed idea. And that has to do with roles, behaviors, activities, attributes that a given society considers appropriate. And I just wanted to call that out, because our society has this binary that there's two genders, male and female, and really trying to put people into those categories. And that is something that needs to change, because that does not work for many, many people in our society. Gender is very fluid and very broad, and we really need to sort of deconstruct how that gender binary, and how we think about gender. So there's the next slide. And so I would say that I just want us all to just check our assumptions, and to acknowledge that the way the system is set up, it's really not set up to embrace people who are gender queer or non-binary, to embrace this gender diversity that we have in society, and to support people as they transition. So transitioning can happen in several different ways. It could be a social transition, where someone starts to identify as transgender and starts to perhaps, change their pronoun or change their name, and to really embrace that. There's also medical and legal transitioning, and there's lots of steps to those processes, and all along the way, the system is not set up to really support that or embrace that. So there's lots of challenges, and there's lots of room for improvement, because the way the system stands now, it's incredibly difficult and stressful to actually fully transition in terms of medical and legal transition. And it winds up being, it varies by state by state as well. So there's not uniformity across the country around embracing that transition. Okay. So something that's super important is pronouns, honoring people's pronouns, and that really conveys respect. When you're honoring people's pronouns, you're asking what their pronouns are, and you're using the correct pronoun. But sometimes that can be easier said than done. So I have, you all will get this slide deck. I have a resource around practicing pronouns and getting comfortable using different pronouns, because that can be something that we all need to practice, honestly. And then I have a great glossary around terms for you all to look at as well. And then I wanted us to spend our last few minutes thinking about kind of circling back to the idea of person-centered advocacy and how out the client is, right? So When I'm working with LGBT older adults, I always am mindful that in many cases they might not be out to everyone. They might be out to some people, but not others. And when someone comes to me with a crisis or with a need or having a serious problem, my job is to always do the best I can to support that client and to connect them with the resources and to meet them where they're at. To Lee's point, when Lee shared their story about their life experience, sometimes the resources that the client needs just don't exist, or they have a 25-year wait. And so that can really inhibit your ability to advocate for your client or your ability to connect them with the resources, because the resources just don't exist, or the ones that do exist are not LGBT friendly, or they have a 25-year wait. So I have a client who I'm working with in the suburbs, and she is a transgender woman, and she's living in an unsafe housing situation. And she is on the wait list to get into town hall, but it is going to be a few more years, I think, till she's able to get in, because there is a long wait. And I'm doing my best to support her in the suburbs and to connect her with programs and services that are affirming in the suburbs. But to be honest, there's just not much out there, and she's really struggling. And so I encourage us all to think about how we can change the landscape and change the system, because the system that we have right now isn't working. It is broken, if you will. I've worked in long-term care. I've worked in healthcare settings, and there really are no skilled nursing facilities that are LGBT friendly in Chicago. And some are attempting to be a bit more friendly than others, but for the most part, that doesn't really exist. And the whole long-term care industry, the whole skilled nursing facility and long-term care services, it really is lacking in some pretty significant ways, just in basic care, not to even mention LGBT affirming care. So especially if you're low income and you're on Medicaid and you're needing to find services that Medicaid covers, those resources are really limited. So skilled nursing facilities just have a long way to go in Illinois to be giving better care to people who are on Medicaid. And on top of that, we have a long way to go for them to be more affirming. So when I'm thinking about advocating for a client, I'm thinking about really asking and drilling down on some of these questions. So some of these questions can help us identify if a place is affirming, right? So you can ask, have you trained your staff? What type of programming do you have? Do you have gender neutral bathrooms? What are your policies around bullying? So when you're looking for an affirming resource, this is a great list of questions to try to parse out if they are affirming. But to my point earlier, sometimes the LGBT affirming resource doesn't exist. So this can only take you so far. So I like to think about it both as the lowercase advocacy, but also the uppercase A advocacy in terms of this checklist of questions we all should make sure our own organizations are doing if you work for an organization. And then if this set of questions are being met with a no, or I don't know, or a blank stare, we can, as a collective group, advocate for this change that we want to see happen across aging service providers, and to really lean in. And the more that we are all advocating for these things and raising the visibility of marginalized and isolated LGBT older adults, the more the movement will build, and the more we'll create the change we want to see. And so I think it's helpful to just use this as a framework for what needs to happen and how we can go about doing it. And so really my call to action for everyone on the call today is really to think about both that internal growth and knowledge and building your skill set as a champion of change and as an advocate to LGBT older adults, and then to move that forward within your organization or groups that you're involved with, to bring that forward and to push that forward and to bring about that change that needs to happen. And then bigger picture, we really need to change the system. So we really need to change the structure, and to not accept the status quo, right? So we need to be innovative. We need to be change makers. We need to push the envelope. We need to not accept the status quo, because the status quo is woefully lacking, terribly underfunded, not LGBT friendly, and to really push that narrative and, to do that across different policy tables, across the state, across this country, and to really move that agenda forward and really to drive that agenda. And so I have a bunch of resources all hyperlinked here. So just some of my favorite resources in terms of advocating for LGBT clients. And again, you'll get all of these in the slide deck after the presentation. All right, so I'm not going to take questions now because we're going to take questions at the end, but if you have a question, you can pop it in the chat and we will take that at the end of the webinar today. All right, stop sharing my screen. Thank you. And Margaret, I think, are you up next, Margaret?
I think so.
Okay.
Actually, Britta, would you enable screen share for me or make me a host so I can do that, please?
Oh,
thanks. Okay. All right, everyone. Well, I'm so excited to be here today to talk a little bit about exercise, particularly for older adults. I've got my email here. Please reach out if you have any questions, any considerations. I'm always happy to chat. So as we think about aging, I want to kind of sort of start with just an idea for us to consider about age. So oftentimes we are very much sort of focused on chronologic age, the number of years that we have been on the planet. But as we're thinking about aging, and I would argue for all people, but particularly for our communities of LGBT, older adults, of the communities living with HIV, we should really be focused a bit more on biologic age, meaning what are sort of our health kind of outcomes? How are our cells, our body, our function aging? Because we could all maybe imagine that person that we know that is 80 years old and is in amazing shape or fitness or good health. And so their chronologic age is high, but their biologic age is really good. They're functioning very well. Conversely, we can think of people who maybe their chronologic age is in their 40s, but biologically they're dealing with a lot of disease states. They're not aging necessarily with good health. And so we really want to think about aging, our focus being more on biologic health. And so how do we actually help people to age well despite whatever their chronologic age is? And so one model that we could really think about to sort of get away from this chronologic age is to really focus on frailty. So on the left of this graph, we have this person that is very fit. And so in this model, this is, the fit person, they're aging well. we have stressors in our life, represented by those kind of dark red balls that push down on our system. So this is like someone who falls or gets pneumonia or is living with chronic diseases, things like diabetes. When we have a lot of resiliency, when we have a lot of kind of capacity in our systems, we can overcome those stressors that come our way. So the example I often use with the physical therapy students is everybody in the class at some point gets the flu. And when they get the flu, they don't feel well for a couple days, and then they bounce right back. That's a fit person. Now, on the opposite end of the spectrum, we have sort of our more frail person. And so when those stressors push down on them, they don't have the biologic health, they don't have that physiologic capability to overcome those stressors. So that's the person that I see who gets the flu and says, I feel miserable. I just need to lay on the couch, lay in bed for a week. They get really deconditioned. They might develop a pneumonia. They end up in the hospital. And then because of lack of access to healthcare, poor, quality of healthcare inequities, it sort of maybe starts a cycle that really leads to adverse health outcomes for people. So as we're thinking about how do we promote and advocate for healthy aging, the key piece I'd like everyone to take in mind is it really doesn't matter the number of years you have. We want to think about advocating for good biologic health and helping people to move from being more frail to being fit and able to overcome any of the stressors that happen in their life. And the end result is really that we want to try to promote good functioning across our lifespan. And so we think about our functional abilities, our activities of daily living, our instrumental activities of daily living. These are the things that people need to do in order to remain in their homes. And like Britta mentioned, we have nursing homes and most people say, I don't want to end up in a nursing home, but particularly for our LGBT older adults, the communities are maybe less safe for them to be out. The quality of care certainly is not great for many or all older adults in those settings, but particularly the most vulnerable. And so if we can really keep people functioning, we can keep them aging in their communities, aging where it is safe for them to age. The sad part is all of us lose about 3 to 5% of strength per decade after the age of 30. And I highlight this because I think one of these myths that we have is like, oh, I'm older. What do you expect? Or people say to me, well, I turned 60 and it kind of everything goes downhill. The thing is, actually, our aging process biologically happens at 30. So sometimes I think our society sort of thinks like, oh, we can put all this off until we're old. And it's not really true. We need to be promoting healthy aging for our teens, for our young adults, for everyone. This is something, aging actually happens at birth. We are all aging. And so we need to promote this because we're losing our biologic function starting at the age of 30. So we need to advocate for some earlier intervention. We know that our muscle strength is probably the primary driver of how well we function, particularly for women. And in this study, they looked at physical function and that found that older women in particular, their leg strength and how physically active they are explains 40% of their activities of daily living. So the message here is really clear. The more stronger we are, the more strength we have, the more physically active we are, the more likelihood that we're going to have high levels of physical functioning, which means we keep doing those activities of daily living that we need. We can prevent ending up in a nursing home. And so one of the key points to sort of think about here is that our strength maximizes at the age of 30. we see strength that declines over our lifespan, and this is most notable for men. And so these graphs here, the graph on the left shows our strength in our ankle plantar flexors. So everyone sitting here can point their toes down like you're pushing down on the gas pedal. That's activating your plantar flexor, the muscle in the back of your calf. And here we see men across the lifespan are stronger in general than women, but this decade past 70 is a period of notable decline. If we think about our communities that are more vulnerable, particularly the HIV community, where we see maybe more accelerated aging, we can bump that back a decade, so that in particular, we need to think about maybe the most vulnerable group there being men around age 60, that they're going to be approaching this period of a lot of loss of strength. And so as they're losing strength, they're more likely to lose physical function and independence. The graph on the right shows the muscle strength in our knee extensors. If everyone straightens your leg and brings your toes up towards the ceiling, that's the muscle on the front of your thighs. Here too, we see the same trend. Men have more strength than women, but this decline that happens in this last decade. So when we look at sort of what happens with exercise, this graph here, or this MRI, I should say, here on the left is that of a 40-year-old person who's very active. They're a triathlete. And so to sort of orient you, this is if we cut someone across their body and are looking down into their thigh. And so this white dot here, that's their femur, that's their bone in their thigh. And we see lots and lots of muscle with just a little amount of fat. So this person's really active, they're building up their muscle mass. We look at now what happens to someone that is more sedentary and they're a little older. So again, we're looking down into their muscle. We see lots and lots of white tissue. That's all fat. So they've lost all this muscle mass from, a younger period in life. And we see a lot of fat that's actually in the muscle. I hope no one's having steak for lunch, because it reminds me of like a piece of good steak where there's like marbling. That's great for steak, terrible for our health. We don't want that fat inside the muscle because it's reducing the quality of the muscle. But look what happens here on the right when we have someone whose chronologic age is higher, but they're very active. Their thighs almost resemble the 40-year-old person. And so the message here for healthy aging is that exercise is probably the single best thing we can do to advocate for good aging. The U.S. National Physical Activity Guidelines came out and have really three kind of key recommendations. First, we need to avoid inactivity. Older adults or people over the age of 65 spend about 90% of their waking hours sitting. We're all being sedentary and inactive right now. It's just kind of how our society functions. It's a lot of what we do. So we need to avoid inactivity as much as possible. We want to strive to meet the guidelines for aerobic activity, achieving 150 minutes of heart-healthy exercise each week, and then really work to strengthen our muscles. And so the key sort of prescription and activities we want to advocate for are that people should be doing resistance exercise about 2 to 3 times per week. The research says that there is a very clear dose-response relationship. And what this means is that the more you do and the more intense of exercise you do, the more health outcomes you're going to have. We only need to spend about 10 repetitions on each muscle group, and we can use weights or bands or machines. The key is we want to lift heavier weights because that's what's actually going to increase our strength to make us function better. We also know that our aerobic function declines with age, and this is also accelerated the older we get. We lose about 2% of our aerobic capacity every year after the age of 30. So it's an enormous loss, and our aerobic capacity is really our endurance. The sad part is there's also a lot of research for people living with chronic conditions, people living with HIV, people that are feeling stigmatized and they're not going to the gym, they're not engaging in activity. The rates of this loss are even more accelerated. And so in this graph here, we see aerobic capacity declining over our chronologic age, even sort of when we are exercising. And this graph on the right here shows the amount of the percent changes that we lose each decade. And so you'll see in our 20s, we're actually gaining, we're not losing any aerobic capacity. But as our chronologic age increases, then women tend to have a loss in this aerobic capacity. And so what the end result for people is they say, I'm just really exhausted. I'm more fatigued. I don't have the energy to go out and do things that I need or want to do. So people that are already more vulnerable are likely maybe a little bit more isolated in the community, simply don't have the physical capacity to engage. And so as people become more isolated, they're more likely to have mental health needs and depression and anxiety, and it starts a vicious cycle. So if we can get people's aerobic capacity up, we give them the opportunity to engage in all the things they want and need to do. So what do we do for aerobic capacity? The thing we should really be advocating for is at least 3 days a week. We're again doing this sort of dose-response relationship. If we're exercising at more intense levels, our ideal intensity is where you can talk with another person, but it doesn't feel very comfortable. We're doing this and trying to achieve 150 minutes per week and really doing whatever gets your heart pumping. If it's dancing, swimming, biking, walking, cleaning your house, whatever it is, get your heart rate and respiratory rate, your breathing rate elevated to that level where you can talk, but it doesn't feel comfortable. The third component that we really want to advocate for is to think about how people maintain their balance. We know that people over the age of 65, 1 in 3 fall every single year. These rates are actually much higher for communities living with HIV because they have such a higher prevalence of things like peripheral neuropathy, which affects their sensation and puts people more at risk for falls. We also know the more isolated people can get, the more they're not kind of getting out there and being active, the more at risk they can be. So we maintain our balance through 3 very complicated systems. One is called our somatosensory system. It's our muscles and it's our nerves that are giving information about things like the touch and the pain and pressure to our brain, and our brain then sends it back down to our muscles. We also use our eyes. About 70% of our balance is through our eyesight. And so it's coordinating our eyes to drive what our muscles do. And then our inner ear. So this is kind of the ability to turn your head and not just fall over. We know, unfortunately, that we lose strength as we get older. We lose visual acuity as we get older. We lose vestibular function as we get older. But these losses, unfortunately, are all accelerated when we are not active, when we are more sedentary, when we are living with chronic conditions. And so the message really becomes clear. We have to use it or lose more of it. And so my advocacy message is for us to get out there and be active. When we want to work on balance, it needs to be done in a very highly challenging way, at least twice per week. The research is clear. This is an area where you need to spend at least an hour a week really focused on working on this and doing anything that challenges our balance so that we can actually feel slightly unsteady when we're exercising. I want to mention a number of resources because I think this is the challenge perhaps for many people, and I'm going to say broadly people over the age of 50, that there's a lot of exercise classes out there. You can go to senior centers, the Y, YouTube, everybody seems to have exercise classes. What we don't necessarily have are exercise classes that are tailored for the conditions that people might be living with. And we don't have a lot of opportunities for safe spaces for people that might be members of the LGBT community, HIV communities, some of our communities that really want to ensure that they're not feeling stigmatized if they're going to the gym. So I want to put in a plug to say, contact me at CJE. We are very fortunate to have a grant from the Administration for Community Living, where we're providing some Zoom exercise classes specifically tailored and safe spaces for communities of interest here. So reach out. And then the other piece I want to really leave us with to advocate for is we need to create cultures of movement. And so a lot of times people think, oh, exercise, it's horrible. I want to like do all that. So we can think about exercise and movement like the idea of a movement snack. Just like you wouldn't necessarily make a whole entire meal out of a candy bar. That's not what you're going to eat all day, but it's okay to have a candy bar here and there. The same idea kind of goes for movement. Rather than thinking like, oh my goodness, I need to do this whole fitness routine, we can think about how can we engage in movement throughout the day. So can we do a minute where we're marching in place? Can we do 30 seconds where we do as many squats as possible, or a minute of wall push-ups? In our communities, can we create cultures where we might start a support group by saying, okay, we're going to just do a 1-minute walk before we kind of dig into our activity, or before or after a community meals program, we're going to do 2 minutes of, a minute of squats and a minute of push-ups just to be active. Because one of the things I think we know is that it really takes a community and it takes a lot of social support to start on a wellness journey. And so if we in our communities can make a culture that promotes movement, it feels much more supportive and gets people engaged in activity. Because we know every minute counts. And for the best health with aging, we want to encourage people to sit less, move more, and advocate for yourself and others to get active. So with that, I really want to say thank you. Please put questions in the chat and reach out to me. I love this. I could talk about this for hours and hours and hours. And if you're interested in the classes that we are doing, particularly for the LGBT community, for the HIV community, please reach out and I'm happy to forward information. Thank you so much.
All right, I believe it's me next. Should I just jump right in, Kim? All right. Well, thank you. Thank you, Lee, for sharing your story earlier. Britta really highlighting the stigma and challenges and barriers for people aging. And Doctor, I got a lot to digest. I'm pushing 60 here. I'm looking at your snacks, and I think somewhere in your presentation, you said you can push us back a decade. I'd like that secret. So, but I digress. My name's Brian Gooding. I use he, him, they, them, anything, respectful pronouns. And I'm here to kind of share my personal story and journey of living with HIV. I'm gonna, if we can kind of go back in time a little bit, 25 plus years ago, 1995, 96, I think the Macarena, I looked back to what's some of the things that were hot in 1996. And the Macarena was one of them, TLC's Waterfall. I remember dancing that, those kind of things. But I was a young man. I just, I had a lot more hair then. I moved into the city at that time. I was working at a gay bar. I was working part-time as a hairdresser, living my best gay life in the city in the mid to late 90s. One day, I woke up and I had a rash all over my body. And I thought, well, what the hell is this, right? And I was young. I didn't have any insurance or anything at the time. And my friend that told me, well, you just go down to the health department. They'll help you out there. So I went down to the health department on Clark Street. It was across the street from, I don't know if anybody, I'll age myself here, remembers the Century Mall, but there was a health department branch across the street from Century Mall. So I went in there and they did, doctor saw me, did a series of tests, and one of those tests was an HIV test. So back then, unlike today, where you can get your test results in like a minute, we got an Insti test, right? 60 seconds, there's your result. We had to wait up to 2, 3, sometimes 4 weeks for that ELISA or Western blot test to come back. And so I waited for about 3 weeks for those results, and I go back to the health department. They call my little number, because at the time they gave you a number. They didn't want to identify people in the waiting room. And the doctor brings me back and says, sorry, Mr. Gooding, your test results came back positive for HIV. A little bit of silence in the room. Since then, I'm a licensed tested counselor from the state of Illinois and providing HIV testing. But I know at that point, when you hear that, any devastating diagnosis, all of a sudden it becomes Charlie Brown's teacher, right? All you hear is whoop, 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 as the doctor's trying to tell you what's going on, and you're trying to process that information. But I left there, I didn't get very few resources or referrals, no medication. Really, I left out of that office that day, and I remember walking out the door, and I didn't think, at the time, people were dying. This was the 90s, right? This was the 90s. People were still dying of HIV. Protease inhibitors, those successful, they really didn't come around until, I think it was December of 95, right? This was really early 96. And I remember walking out the door and thinking, I didn't think, oh my God, I'm going to die. That wasn't my first thought. My first thought was, oh my God, I want to live, right? And what do I need to do to do that? So I did some research, searching out resources. I had a friend of mine at the salon I was working at. They were involved in a study, and I got hooked up with that study too, and started taking medications. At that time, I can really tell you I believe they started me on AZT. The cure was worse than the disease. Talk about, nausea, vomiting, and diarrhea like you wouldn't believe, and I, as a young man, and I was taking pills that, it was a guinea pig. And as a young man, I thought if I wanted to go out that night and hang out with my friends at a club, I wouldn't, this may sound kind of gross or funny, but I'd skip my pills at night because I didn't want to shit my pants out in the club, right? So I was making decisions about my health and life based on that medical care I was getting. At one point, I cut my medications in half, and nothing really happened. My blood work didn't change, so it led me to believe the doctors were over medicating me. And at one point, I was taking upwards of 15, 20 pills a day. You were taking pills for HIV, you were taking pills for the side effects, you were taking pills for diarrhea, you're picking all those kind of things. So, and I like to think, but we've come a long way. Today is a very, very different picture for people that are living with or diagnosed with HIV. I like to say that I took 20 pills a day, so the young folks now can take 1 pill a day, right? 1 pill once a day. My HIV has been living with me on my terms. I make the rules for about 26 years now. As I take 1 pill once a day, which manages my HIV. I am undetectable, which means I cannot pass that virus on to others through sexual contact. So that's U equals U, treatment as prevention. And I think we're really at a kind of crossroads here. We're for a long time, and I've been doing, as you started my bio, I've been working in the HIV field for about in advocacy or program management, prevention for a better part of 2 decades. And there was a time when I thought, geez, I don't know when this is going to come to an end, right? And here we are at a crossroads where people talk about, oh, a cure, let's find a cure, let's find a cure. Well, hell, we don't have to wait for a cure. We have what we need now to end this epidemic today. If everybody stopped, dropped, do their status, gotten care, reach that undetectable level. If people at risk for HIV would get on PrEP, right? That's a pill people can take to greatly reduce the chances that they may become exposed to HIV. If we, through the use of those 2 tools, we can get there. We can get to what they call functional zero, which means there's no longer enough virus to support itself in the community, right? And we have a plan to do that in Illinois and across our country by 2020, by 2030. We want to get there, but it's a long road. I am not a survivor. I'm a thriver. I am living well and thriving with HIV. And there's some studies that came out, I believe, a while back that HIV levels have kind of leveled off over the last decade. But and that's kind of sounds like great news, but that's kind of a misnomer, because when we really drill it down and we look at marginalized communities, Black and Indigenous people of color, our trans community, these communities are still in crisis with this epidemic. So how are we using our knowledge, and historical knowledge from folks like me that have been living it for a long time, to make sure that we're bringing everybody along in this journey, right? We can't get to zero unless we bring everybody along with us. So I think, this is a story of hope, right? Because there is, I think, right now we're there's, like I said, there's light at the end of the tunnel. This is not a time to pull back or to think about, oh, what can we do now? It's time to put our feet on the gas and full forward with as much resources and information we can so we can get to that end. And I really believe we can get there and end this epidemic in the United States without a cure. And when it comes to aging, I am aging with HIV. There's a statistic out that over 50% of people living with HIV are 55 or older. So that in this conversation of folks living of aging, that's a special population that really, because we can't get to zero without those folks too, right? Those people that are living with HIV over 55 and making sure that they have access to the care, the medication, treatment, housing, all those things that have been identified over the last hour today. We've got to bring those folks along with this too. So I encourage folks to, well, I'm not going to encourage folks to anything. We're going to hear about some legislation here in a little bit. We're going to watch a couple of videos about disrupting disparities, those things that are really keep people from engaging or retention in care, right? What's keeping me from getting tested? What's keeping me from getting into care? What's keeping me from maintaining my care? And those are often come down to disparities and social determinants. We're also going to hear about some legislation. I'll be happy to hear about that. And I encourage folks after the call to really act on any calls to action around legislation, because we need, as I think Brent said earlier, we need to change those systems and that structure in order for people to have those health outcomes that we're looking for. And that starts with advocacy and legislation. So without further ado, in the interest of time, I will move it on to our next speaker or our video.
When I was born, August 9th, 1949, homosexuality and homosexual acts were universally against the law. This building was formerly the 19th District Police Station. And what's significant about that is that in the old days, when gay bars were operated like speakeasies in dark and sullen places and regularly raided by the police, gay people, gay men in particular, were arrested and brought to this building. And what makes this building so important is the fact that this is what we call an LGBT-friendly senior apartment building. It provides what few LGBT residents get to experience in other places. Oftentimes, to obtain housing or other services, LGBT people have to go back into the closet, meaning they have to deny their authentic selves and their authentic lives.
We've made a lot of strides in the last 20 years. I mean, 20 years ago, I never would have thought that my wife and I could get legally married. I never would have thought we'd actually been able to create a family. But we still have a long ways to go. The decades of discrimination LGBTQ folks have felt is having an effect on the way we age. It affects how much money we can save. It affects the health care that we can get. And that discrimination is still continuing to this day. Older LGBTQ adults are twice as likely to live alone. 3 out of 4 are very concerned about who will care for them as they age. We want LGBTQ older adults to be seen and to be counted. Their stories of resilience and strength must be told.
Data tells a story. It tells a story that provides the voices of elders themselves in terms of what their lives are like and what their opportunities are and what their challenges are.
It was in 2014 that I came to fully understand that despite how I appeared and despite how I sounded, inside, I am, and I always have been, female. I was scheduled for hernia repair surgery, something very, very common. When I got to the surgery center, I was supposed to fill out a form, and I walked away without it. And then I heard, "Oh, sir," and that is a real telling moment, because it speaks to precisely what it is that trans folks encounter in their daily lives, being misgendered. It's an awful feeling. It's an awful experience. One becomes accustomed to it. One can predict it, but it still hurts. It really does.
As an older LGBTQ adult myself, we know that caregiving is very difficult as we age. Many of us are taking care of our friends who we consider our chosen family. Because of discrimination we've seen over the years, we're not able to depend upon some of the traditional family supports that others have.
We need the legislature to take a series of steps that will guarantee equitable access to elder care and services in the state of Illinois.
Organizations like AARP and SAGE and others that are dedicated to advocating the interest of the aged are very important to us.
What's needed is not only policy changes, we need change of hearts. That's what we need. That's what I hope for.
We are prepared to live actively and to contribute passionately until the day we die. But we don't want to die before that. We don't want to be socially ostracized. We don't want to be distanced. We don't want to be isolated. We want to live. We don't want to be erased.
Hello, everyone. I'm Mary Anderson. I'm Director of Advocacy and Outreach from Northern Illinois for AARP Illinois.
And hello, everyone. I'm Mike Ziri. I'm the Director of Public Policy at Equality Illinois, the state's LGBTQ civil rights organization. So excited to be here with you today. Mary, take it away.
Thank you. So as you just saw, we just heard the stories of LGBTQ older adults here in Illinois. And SAGE did together that really looks at the disparities, the challenges and the solutions for 50 plus LGBTQ Illinoisans. So we're going to go through that report today and kind of see what we learned. So SAGE and AARP Illinois joined forces to put together this report. And if you don't know SAGE, SAGE is the world's largest LGBTQ organization that works with older adults. And what we have some key findings in this report. And what we found is why older LGBTQ Illinoisans are resilient and live strongly, there's a lot to be done to support older LGBTQ adults here in this state, especially considering the COVID-19 pandemic. And the disparities we found in the report, they're rooted in a lifetime of discrimination, a lack of legal and social recognition, a reliance on chosen family, and also reduced access to inclusive services and also other social determinants of health. And then those disparities, they're compounded if you look at LGBTQ older adults of color. And that's 1 in 5 LGBTQ adults of color. So in the report, we looked at these issues kind of in 3 areas. We looked at economic security, health and well-being, and caregiving and social connections. Now, in economic security, what we found is that 1/3 of LGBTQ older adults live at or below 200% of the federal poverty level. And what kind of this means on a daily basis is that 83% of LGBTQ older adults rely almost entirely on Social Security benefits to support them in their retirement years. But unfortunately, many LGBTQ older adults do not have access to the retirement benefits of their partners or the retirement pensions of their partners. And until just recently, they did not have access to Social Security survivor benefits. However, there's a new decision, a new action just taken by the Biden administration that is changing that. And so there'll be much more access for older LGBTQ older adults to have access to Social Security survivor benefits. So a real improvement. Now in healthcare, this was much harder. There was not as much data on healthcare, but what we did find is that surveys of LGBTQ older adults and Chicago and broadly found health insurance and access to physical health services among their top priorities. What the survey also found is many older LGBTQ older adults have a very difficult time finding healthcare providers that are inclusive and recognize their social identity. Caregiving and social connection. Now, this is where some of the most staggering reports was. So what we found is that 21% of LGBTQ people over the age of 50 have provided care to their friends. And so what that means actually on a daily basis is that 3 out of 4 LGBTQ older adults live alone. This is a result of decades of legal and social discrimination. So many of us older adults here in Illinois, LGBTQ older adults in Illinois, do not have traditional families in order to rely upon for care as we age. We don't necessarily have younger adults in our family or have spouses that we can rely upon. And so many times we rely upon our friends. But those friends are aging at the same rate as we are. And also that makes it harder for us to access caregiving services. So what are we going to do about this? Well, we put together a series of policy recommendations, and we did this in collaboration with Equality Illinois, Pride Action Tank of AIDS Foundation of Chicago, Center on Halsted, and RRF Foundation for Aging. And we put together a comprehensive strategy to support LGBTQ older adults, equal access to inclusive programs and services, as well as looking at the need for LGBTQ inclusive data collection. And we've actually taken the first steps in order to make these recommendations a reality. So I'm going to turn it over to Mike to talk about the legislation that we're working on right now.
Great. Thank you so much, Mary. And again, as Mary said, from this report, we have developed a really exciting piece of legislation that begins the process of disrupting some of the disparities that Mary addressed and that were in the report from AARP and SAGE. And so the organizations that Mary mentioned, and we throw them up on the screen, these organizations, AARP of Illinois, AIDS Foundation of Chicago, Center on Halsted, Equality Illinois, Pride Action Tank, and SAGE, came together on the Disrupting Disparities for LGBTQ older adults and older adults living with HIV legislative package. Senate Bill 3490. We have two amazing champion sponsors, State Senator Karina Villa and State Representative Lakeisha Collins, both passionate advocates for older adults and LGBTQ people. And so I've been championing this bill, which passed the Illinois Senate in late February, 37-9, 37 yes votes, bipartisan. Really excited for the bipartisanship on the bill. And what does the bill do? Let me scroll up for you here. Very simply, it does three things. One, it creates a 3-year Illinois Commission on LGBTQ aging. Really exciting to get this commission rolling. And then it does two things at the Department on Aging. One, it establishes the position of an LGBTQ older adult advocate, someone who will ensure that as programming and policymaking are conducted by the state, particularly the Department on Aging, that the needs of LGBTQ older adults living with HIV are incorporated in those programming and that policymaking. And also, so the community has someone they can go to at the state to answer questions about issues of protections, and civil rights, and any of their needs being met. So we're really excited for that position to be established at the Department on Aging. And the third piece of the bill is that state-funded providers who provide services to the Aging Network, they will have to undergo cultural competency and awareness program training for LGBTQ older adults. And this is something that Director Basta, the Department on Aging, has already been doing for the past few years and has been doing tremendous work. And to honor her leadership and the leadership of her team at the department, we want to ensure that these practices continue. So we want to put them into statute and make them part of this package. So really exciting, this 3-part bill. As of today, and I know we're recording this today a little early for the actual event on April 27th, but as of today, the bill is poised for a vote by the Illinois House of Representatives. Really excited, again, for the leadership of Senator Collins, Senator Villa, and to see what we can do in the coming years with the Commission on LGBTQ Aging, with the position of the LGBTQ older adult advocate, and with the state-funded with the required training for state-funded providers. And again, this is just the beginning. This is just the beginning of this work. There's a lot of work that's going to be needed to disrupt these disparities that are impacting LGBTQ older adults living with HIV. But this is an important first step that really will place Illinois on the map for the protection and the advancement of justice and inclusion for LGBTQ older adults living with HIV. We have a lot to be proud of in Illinois already with our legal protections for LGBTQ folks. And this is just another important step in that direction. So really, we thank all of our partners on this bill, and we thank Senator Villa and Representative Collins for being the great champions they are. Again, the bill is passed the Senate. It's waiting for a vote in the Illinois House. I'm very hopeful for its passage and then approval by the governor later this year. But now I want to turn it back over to Mary to talk about another legislative initiative. So Mary, thank you.
Yeah, so we want to talk about another piece of legislation, which we see kind of as the next step in this work. And this is HB 4771. This is a family caregiving tax credit. And what's different about this tax credit is that it actually includes LGBTQ families and chosen families. The way that those families are defined in the statute, it includes, it has a much broader definition of family caregiver. And so it includes LGBTQ families and chosen families. If this tax credit passes, this would be the first time in the country that such a tax bill passed at the state level that included LGBTQ families and chosen families. So we are thrilled about this. And what the bill would do is it would provide an annual tax credit for those family caregivers to cover those expenses, things like transportation, additional supports at home, additional services at home, different materials and actually things that you have to buy in order to change the home, such as grip handles, that type of thing. So it's going to make it possible that you can actually could deduct up to an average out-of-pocket expenses of $7,200 a year. So this is our next step in this process. This bill right now is in committee in the state legislature of Illinois, and we're hoping that next year we can get this passed and turned into law. So that is where we are right now in the state legislature. So Mike and I are excited about where we're going with this work, and we cannot wait to see what's going to happen by the end of the legislative session. And we hope by the time you do watch this video that we'll have several victories to talk about.
And hello, everyone. It is Mike Ziri here, this time live, not recorded. And we recorded that video back in late March. But since the legislative session concluded on April 8th, I wanted to give everyone an exciting update that the bill that Mary and I talked about, Senate Bill 3490, the bill to disrupt disparities for LGBTQ older adults, it has passed the General Assembly. It passed the Illinois House 71-32 bipartisan support, including the Republican leader in the Illinois House voting for it, Jim Durkin. So really exciting to have that bipartisan support in both chambers. The bill will soon be transmitted to the governor, we know he's supportive. We know he'll sign it. We're very hopeful he might sign it maybe next month, which is Older Americans Month. And of course, June is Pride Month. So some perfect opportunities for the governor to sign the bill. But really excited about all the support and, just some quick next steps. One, the governor has to sign the bill for it to become law. But two, we are already with Kim and Mary already engaging with the Department on Aging on implementing these different provisions, putting the commission, getting the Commission on LGBTQ Aging together, working on designating the LGBTQ older adult advocate, and also, working with the department on the training component, which, as we said in the video, Director Basta has already been championing and leading. And so that work is already being done by the department. We're just excited to have it put into law as a real legacy achievement for the director. So that's where things are. Really excited by this bill. Illinois is really becoming a leader. Well, it is a leader, not becoming, it is a leader. And this bill really just keeps Illinois in the forefront across the country in policy to support and affirm LGBTQ older adults and older adults living with HIV. So really excited by that. And so I want to turn it over now to Terry Warman, who will moderate a Q&A.
Terry, you're muted.
That's the only time it's happening. Oh yeah, Don, thank you so much. So I had just been in the chat because Mike says that the governor's going to sign it, but it's always great, and since he's our governor, all of us, that it's great to call the governor or email the governor or text the governor and to say, please sign the bill. And thank you so much for supporting our community. They so often do not hear thank you afterwards. They just hear from us when we don't like what they're doing. So that's my little thing. Okay, so Dr. Margaret, are you there? Because you seem to be one of the people that there were some questions, and I think you were kind of hinting at some of this, at the very end of your presentation. But Ayana had asked a question if there's any data or reports on physical decline in strength for trans-identified older adults, and any differences, similarities between cisgender and transgender non-binary older adults when it comes to healthy aging. Have you seen any reports or studies there?
Yeah, this is a great question, and really an area where there is little to absolutely no research. So hopefully this is going to be something that is addressed, over the coming years, but to date, there really is no information. So there's a lot of, I can even just speak to, some of the research studies that we've been involved with, where we're looking at sort of physical function levels, and what they provide is men and women, and that's it. And so we've had the conversations of like, well, what do you do, and what should the sort of the comparison be for individuals that are trans, and there's discussions sort of about, well, the length of time people might have been on a hormone replacement or things like that, but it's all speculative. There's no research right now, unfortunately.
All right. How do you think that we could help make that happen? As a group or as individuals, how do we make that happen?
Yeah, to me, it is a big area of advocacy, because particularly sort of in the field of geriatrics, there's a lot of physical function measures that geriatricians, that physical therapists are using to say, okay, this person scored this, like they should be approved for surgery, or they should, see a physical therapist. But if we're really just operating on these kind of binary kind of thresholds, it's leaving a lot of people sort of not having their health needs addressed. So we really need advocacy for more research, for more funding, to say like, what should sort of the guidelines be, because we can't just throw up our hands and say, we don't know, like, so be it. So we really need strong advocacy to say we need kind of these thresholds and research addressed, so that we can really tailor and individualize healthcare for everyone.
Great. And you also had mentioned at the end, but there were a couple of people who were kind of reiterating that whole idea of how do older adults, in particular LGBT older adults, be able to get the activity if they don't feel safe in going out into their communities, where tech issues may be a problem. And I know, CJE and so many other groups, we're all trying to get, stuff out on Zoom, et cetera. But, and also, they can't afford gym memberships. So can you just kind of go back and kind of reiterate some of the things that, especially kind of what we all who are here today could do?
Absolutely. So one of the key things I think is environmental safety, right? And also just think about Chicago. 10 months out of the year, I don't want to go outside because the weather's terrible. So we need those indoor spaces. So I'm a big proponent of saying, can you go to Target? Can you go to the Jewel? Can you go to any spaces? Can you advocate in your church or other places you go to say, hey, can we just use this space to walk around? Take the shopping cart at Target and just go up and down the aisles, or a place, whatever is your sort of place that you say, okay, this is a place where I feel safe and comfortable that can be an indoor spot. There's lots we can do in our homes, and there's lots we can do without equipment. So this idea of movement snacking really says you don't need like a defined exercise program. You need to maybe just turn on some music and get moving, dance, do whatever feels good. So that if you don't have internet access to YouTube or things like that, it can be as simple as like, let's just do some squats, let's do push-ups, let's go up and down from a chair, and use this idea of as many repetitions as possible. And this is a research study that we did actually last year with a group at Penn State, where we said to people, all you need to do is 30 seconds of push-ups and 30 seconds of squats. That's all you're going to do every day. And you're going to do as many repetitions as possible. And people got stronger, and they actually did it. It didn't need any equipment. They just needed a minute, and you can do that throughout the day. So we don't need equipment. We just need to move and to sit less and move more. So replace our sitting activities with standing. Can you march in place while you're watching TV? Can you, do those kinds of things? So it doesn't have to be overwhelming, and we can overcome those barriers of access to facilities or outdoor spaces.
Yeah, Mara had a kind of the same thing for you during the commercials, just get up and move or whatever. And these days, with as many commercials that are now in shows, it's like, I can get a whole half hour in an hour show of exercise just to do it, and I think too, because I was working on this kind of for myself, is that, when you talk about squats or other things that, for most of us, it's like, oh my gosh, but having a chair and just doing little bits at a time, and maybe you only get an inch, and then maybe you start getting 2 inches, and then, or being able to do some leg lifts for balance. So a lot of times people hear, oh, you've got to do, like just all of this stuff. And you're right. I love the movement snacks. That's a great.
Yeah. Something is better than nothing. And so I think that's the message we should really advocate for, because particularly in more vulnerable communities, I think there's other priorities that people need to prioritize. So it's just not really the message we need to say to people that are housing insecure, like, oh, you've got to go find a gym and exercise 3 times a week and stuff like that. No, like, how can we advocate for little things that people can actually do that will make them feel better and improve their health?
Thank you so much. So I'm opening this up. Does anybody have a question for any of our speakers? And as you're thinking that, you're going to get a number of resources, like Britta said, with her PowerPoint, and we have a handout that has an enormous amount of information. Kim just said, I encourage people to take Mike up on his offer to email him to get the information. And so anybody have a question? Oh my, Kim, we did so. Oh, Kate.
Hi. I was thinking back to Britta. I'm not sure exactly how to phrase this. I've been like typing in the chat and then erasing for the last 5-10 minutes. But Britta, I'm interested in hearing, I'm just so struck hearing you talk about the lack of particularly skilled nursing facilities that folks can go to, that there's really nothing in Chicago that's LGBT affirming. And I'm wondering what you kind of see are the next steps, or how we can, as a community, work on that, because it's such a need. Yeah, such a need for everyone as we age.
Oh, sure. Thanks for the question, Kate. So in thinking about skilled nursing facilities in Illinois, I think about the lack of funding and just the lack of quality of care, because COVID has shown, right, there were a lot of deaths in Illinois nursing homes, especially in nursing homes that had 3 or 4 person rooms, that were shorter staffed, and so it doesn't leave a lot of bandwidth for that skilled nursing facility to tackle LGBT issues, right? Like, let's talk about, trans policies and be trans inclusive. And they don't have enough workers to cover the next shift. Their residents are, waiting to get the care that they need. They're in crisis, really. So I think we need to address that first, at a basic level, right? To really raise the bar and to improve the quality of services that all, residents here in Illinois deserve for, as they age and as they need skilled nursing, and that will give the community more bandwidth to tackle other issues, and that will give us here in Illinois more leverage and more latitude to bring this issue forward, right? Because it's like the cart before the horse. It doesn't really make sense to tackle it now in a big way when there's all these other gigantic problems happening. So I think it's really, kind of big picture and then kind of zoom down a bit. So, and from what I found, the communities that tend to be the most aware of LGBT aging issues and trying to address this, they tend to serve higher income people and they have better qualities of care, they have better health indicators. And so that is good for people who can afford it. But again, for people who can't afford that and who are and their payer source is Medicaid, we still have a really long way to go. Yeah, I mean, and at the root of the issue, we also have to think about how to address culture change with other seniors and other people who are living in these communities, because that's a really big problem. The staff can be trained, the staff can be LGBT affirming, the policies can be amazing, but when your roommate that you share a room with 24 hours a day, 7 days a week is homophobic and making gay slurs, you are not going to feel safe, of course. And so that's the other side of the conversation that hasn't gotten a lot of attention. So I think really big picture policy issues, kind of bringing that forward, but also how can we as an LGBT community help solve this problem ourselves? So One Roof Chicago is an example of that. And so Don, I see that you have your hand raised. I hope that you're going to bring that forward as a potential solution on how we can really flip the script and come up with something innovative to address the problem. So Don.
Okay, thank you, Britta. I was going to say, in conjunction with what you're saying, is that we have allies out there that we need to make connections with, because there is awareness beyond our immediate group of the problems of LGBT aging. One of the groups that I might suggest we contact and invite into our circle is the Jane Addams Senior Caucus, which has made a major commitment to becoming welcoming and culturally sensitive to LGBT elders. And they are working on initiatives with nursing homes and other congregate settings for aging people from the point of view, not of the privileged, as Britta said, where a lot of emphasis has been placed, but for regular people, for survivalist people. And they are working across communities of color, working class and poor people, and that's where the real need is. So, if we can foster some collaboration, I think that we can really step up our effectiveness in dealing with this issue.
Brian, you had your hand up?
I just have more of a comment in just recognizing the different challenges between folks that may be living in our urban areas than our folks that are living in rural areas, right? So when we think about Chicago, there's a gay community there, right? So there's power behind that, and being able to garner that and make change and to advocate for those kind of services within the city of Chicago or the metropolitan area, right? But I just want to more as a comment, just to make sure that, you know, there are folks that are in Decatur, there are folks that are in Jonesboro, there are folks that are in other areas around the state of Illinois, where the issue and the problems and barriers are extra, you know, exacerbated. So I just want to make sure that when we're doing this work, that we make sure that it's inclusive of all communities.
Thank you, Brian. And I see Billy shaking his head. We are excited to have Billy Rogers from Downstate, Illinois, with us as well. Billy, I'm putting in, can you put your email in the chat if people want to find you as well? I think he's doing that. So Don, I think you are, there it is, from Billy, the Rainbow Cafe. So check them out, Downstate. Don, I think you are up for our call to action and collecting CEUs. I know those are things people have been waiting for. So Don, take it away.
Right. Let's get this thing straight on CEUs. I think the contact is through the Center on Halsted. Britta, who is the contact person?
Sure. So we're going to be putting in the chat a link for people to take a survey, an evaluation if they need CEs. There it is. Thank you. And that'll also go in a follow-up email. So if you need CEs, take that evaluation and you'll get the CE over email next week from Ing at Center on Halsted. Thank you.
Okay. And in rounding out, before I get to the call to action, I do want to thank Margaret for showing that slide of the cross section of my thighs. Thank you very much, Margaret. As you can tell from that slide that she showed, I'm whiter than I thought. So we're going to work on getting a little more color in those thighs. Thank you, Margaret.
Well, thanks for agreeing to be the model there.
And in addition to that, in all seriousness, in the call to action, what I want to do is acknowledge some things that I think are very important. One is we can't get from where we are until we know whence we came. And it's important that we examine our history and that we examine our location. It's significant that we're in the state of Illinois, the state where the first homophile organization in the United States was formed, the state that was the first to decriminalize homosexuality, all of those things that we've come through. And as a member of the generation that is generally referred to as the first out generation of LGBT elders, I can tell you that we've seen a lot of change in our time, and we've been a part of a lot of change. Not only decriminalization, but depatholization of homosexuality as we've seen it taken, removed from the DSM as it was once upon a time. As we've as we've been turned historically from the face of God in every major religion, every house of worship, and we've changed those things, and we now have welcoming congregations and other things. There's been a lot of change in our lives. And for those of you who are younger, I hope you take a look at that path, because what it does is it gives you a starting point for where you have to go as you take over. And our community is a community that is very diverse. Actually, the homo community is unique in its heterogeneity. We come from different places. We are not a community of origin. We do not come from families of origin. We come together as a community of choice, and we develop families of choice. So our intergenerational relationships are very important to us. And for those of you who are younger members of our community, our younger advocates, we welcome you, we depend upon you, we look to you not only as the recipients of our legacy, but as the people who will carry on our missions. You are important to us. We cannot get along without you. We need the social connection that comes from intergenerational relationships. And you will notice in my last comment, before I let y'all go, in my identity on my side, on my Zoom screen, I identify not only my pronouns, but I also identify my age. And that's because I will tell you, as a person who was born into marginalization on the basis of race and sexual orientation and gender identity and class, I wasn't pleased at growing into a new ism when I reached my 50s and 60s. And so part of my campaign is to have people appreciate the aging. In the United States, we have a culture that says that as we grow older, we grow lesser. But that's not the predominant culture of the world. In many societies, and in most society, people are revered as they grow older for the value of their life experience. And I can tell you, I see aging not as becoming less. I see it as an achievement, as an accomplishment. And I can tell you, I've left a lot of people along the way, people who were victims of war and drugs and issues of discrimination on all different bases. And I made it, and we made it, and we're all here together. And I hope that you can find value in the success that we've made in aging. I invite you to be a part of this effort. I invite you to be a part of this community. I invite you to be a part of this family. We all need each other to carry on these efforts. And I look forward to working with you all and continuing in our successes. Thank you. Terry?
I'll pop in here. Hi, everybody. It's Kim Hunt. It's okay. No, you did the right thing. Just want to direct folks to the chat. There's lots of resources there that we encourage you to take a look at. When we send the thank you email out, we'll also send the PowerPoint decks. We'll send a link to this training. We'll also send a resource document that's currently in the chat. And I also want to point out that we will have 2 other trainings coming up for LGBT plus older adults, one for storytelling and one for, or 2, I should say, for advocating for change. So stay tuned for those. Pride Action Tank's newsletter link is also in the chat. So if you are not signed up for our communications, please do that so that we can keep you apprised of what's going on. And I'd like to thank the Out Aging Committee for helping to put this and all the other trainings together, many members of which are here on this call. So thank you all for coming today. And we want to give you 3 whole minutes back in your day.
Well, I'll take them. Because I'm aging quickly. I need my minutes.
Thank you all.